Dear friends, ladies and gentlemen, it's a great pleasure for me to give this talk on NAFLD, what you need to know. Here are my conflicts of interest. So I think the first thing I would like to talk about is this growing confusion about nomenclature, which has become an important area of conversation. Now, this all started back in 2020 when we published a paper which was a review article discussing the complexity of NASH, where age, microbiota, genetics, metabolic health all interact with each other and contribute to varying disease subtypes, variable natural history, inter-individual variation, and potentially variable response to therapy. And this led to a few statements that there was probably a need to revisit the nomenclature to get more clarity. And very quickly, a number of folks decided that this should be called metabolism-associated fatty liver disease based on the presence of metabolic dysfunction and coexistence of other diseases, so that this would contribute to stratification for trials, for NIT development, and for inclusion into therapeutic trials. Now, when you actually see whether we accomplish this with a new name such as MAFLD, let's look at some of the criteria of what the name actually means for the disease. And these include, as shown on the left, whether it accurately reflects disease etiology, captures heterogeneity, environmental exposures, alcohol, risk stratification, identification of treatment responses, a framework for disease monitoring, accelerates NIT, reduces stigma, or provides a framework for precision medicine. Well, if you look at our current classification, it partially reflects disease etiology, allows risk stratification via fibrosis staging, and certainly has provided a framework for NIT development and disease monitoring and therapeutic development. Now, the proposed system, as you can see over here, does not really significantly enhance these critical other needs. So I believe there is probably a need for continuing work to get more clarity and especially focus on the future, where we will be thinking about fatty liver disease in the larger context of metabolic health and looking at subclusters of people with unique patterns of outcomes, and that will be the basis for classification in the future. So this remains an active area of conversation, and there is a global process going on between AASLD and EASL to develop this. So what to do in the meantime? In the meantime, the best is to follow this classification that has been appropriately approved by both the FDA and the EMA, where you talk about the disease phenotype, its activity, the disease stage, and the etiological associations, where in an individual patient, one or more features or etiologies may be present. Now, moving forward now into the disease itself. One of the areas that is very hot right now is enhancement in histological assessment. Traditionally, we assess histology by looking at steatosis, inflammation, ballooning, and fibrosis. But there is a lot of observer variability and sampling variability that limits interpretation of these data. So there are other systems that are being developed. This is the PathAl system, which is an automated quantitative system, and it's highly concordant with how pathologists read it. So here you see central pathologist is being compared versus the program. There are other pathologists over here, and then they're looking at interpathologist correlation and comparing it with a consensus mean. And as you can see, it does really well, particularly for steatosis, but even for ballooning and lobular inflammation and fibrosis, it is in the range that it is seen with pathologists. So these are being developed as AI-based ways to improve the concordance and reduce the variability in the reading of the histology, particularly in clinical trials. Now, there are other probably even more interesting developments, and these are work being done by HistoIndex, where in this tropifexor trial, we started looking at single harmonic generation based images of fibrosis in the liver. And what you can see is that there are clearly differences between progressive septa, which have more inflammatory cells, as shown in red within the septal fibers, established septa, which are somewhat more acellular, and regressive septa, which are thinned out and being attacked by infiltrating hepatocytes, which again break up the collagen fibers. And the septa then eventually start breaking as fibrosis regresses. So whereas fibrosis progression follows a certain cadence from sinusoidal to portal to bridging to cirrhosis, when you treat effectively with a drug that treats the root cause, the regression occurs also first in the sinusoids and in the periseptal areas, and then lastly in the portal areas. So these are important things to keep in mind as we think about the histology. Further assessment of histology with using the PharmaNest tools over here further breaks it down, looking at fine collagen fibers, assembled collagen fibers. It can separate out steatosis, ballooning, and actually look at steatosis corrected total collagen proportionate area. And based on this, it can create heat maps of the biopsy, which shows areas of high and low activity, which can then be quantified and produces a more quantitative assessment of activity and fibrosis in histology. Now, these are all work in evolution, but I'd keep a close eye on all of these because these are the leading technologies right now in the assessment of liver histology. Now, moving on to clinical things, which is probably of the most interest right now, let us now look at the clinical course and clinical heterogeneity. So one of the things that has, of course, emerged is COVID, right, in the last 2 years. So this is an important study from 62 million case records, and of which there were about 1 million individuals with chronic liver disease, 16,500 cases of COVID, and 820 cases in people with COVID plus CLD. And as you can see, that odds of COVID-19 with recent encounter for CLD, adjusted for demographics and other known COVID-19 risk factors, are quite high across liver disease. You can see both for alcohol-induced liver disease and for NAFLD, and particularly for chronic NAFLD, you can see an odds ratio between 11 and 13. So this is really striking. So NASH is an important risk factor for severe COVID disease and dying from COVID. The death rate in patients with chronic liver disease, as you can see, was significantly double that in people without chronic liver disease. And COVID-related hospitalizations was also twice that seen in people without chronic liver disease. Now, alcohol probably is not a major issue in Pakistan, but certainly in other parts of the world, there's strong overlap between people consuming alcohol, where up to 20% of the population consumes significant amounts of alcohol. And this is also combined with the same people who also eat a lot of food. And so there is a growing focus on people who have both features of alcohol and non-alcoholic fatty liver disease. By the way, changing the name to metabolism-associated fatty liver disease doesn't solve this problem. A very important area that is emerging is the role of the brain, where the brain, through its genetics, neurocircuitry, experiences such as post-traumatic stress, can manifest a number of problems such as depression, anxiety, social isolation, lead to food addictions where people eat to deal with their anxieties. And this, of course, drives eating behavior and the ability to comply with lifestyle and drugs. Now, this is fed, and of course, what you eat, on the one hand, affects your intestine and the rest of your body's metabolism. And on the other hand, it also affects the liver by driving calories into the liver. And these in turn, when the liver and the rest of the body gets fat loaded and becomes inflamed, There are cytokines, hormones, metabolites, other microparticles from individual cells that go into circulation, and these in turn affect the brain. So this sets up a vicious circle. And what we see now is that there is an overrepresentation of mental health disorders in our patients with NASH, and there is also accelerated neurocognitive decline in this population. In addition to that, there is collinear worsening of diastolic dysfunction with progressive fibrosis stage in NASH, where, as you see, with patients who had no prior history of cardiovascular disease but had NASH with varying fibrosis stages, when you exercise them, their exercise time decreases as your fibrosis stage increases, their peak VO2 is decreased, and when you do stress echocardiography, you can see diastolic dysfunction, and their E to E prime increases progressively. There is also an increased expression of chronic kidney disease in NAFLD, and you can see that the proportion of people with eGFR less than 60 ml per minute increases quite significantly as you go from stage 0 to 2 to stages 3 and 4. And you can see not only is the prevalence high, but you can see that the incidence per 100 patient years of exposure, when you go from stage 0 to 2 to stage 3 to stage 4, increases quite significantly as well. And you can see the odds, the incidence is 4.47 per 100 patient years in compensated stage 4 patients who do not have chronic kidney disease to start with. Another important clinical observation is that fibrosis can regress spontaneously, and that this is associated with reduction in events. So this is work that we did from the Gilead study, where we looked at about 1,000 patients who had a liver biopsy and then followed them up with another liver biopsy in a year, and 176 actually showed fibrosis regression from cirrhosis, I might add. But it was not just sampling variability, because over here what you see is that the odds ratio of having a clinical event drops by almost 85%. And so this is very dramatic. And you can see this both whether you look at it with a classic NASH CRN staging system or with the HX scoring system. So this tells us that even when you get to compensated cirrhosis, there is an opportunity to turn the train back. And this is something we need to understand more and understand the factors that were linked to this regression. And particularly whether weight loss, better glycemic control, use of specific agents can actually do this, because this gives us hope that we can actually modify, even at a very advanced stage, the natural history of the disease. Which of course brings us logically to the issue of evaluation and management. Now, probably the only thing you really need to remember about evaluation and management is that, first of all, if you have somebody with diabetes, hypertension, and who is obese or has increased waist circumference, and you can see this with a clinical examination, their pretest probability of having excess fat in the liver is already very high, in the 70 to 80%. If you were to just say that they had fatty liver disease, you'd be right 3 times out of 4. The more important question is this the kind of fat that is likely to produce a bad outcome for them? And what you need to remember, and this is so easy to do, is to just look at the FIB4. And you can use either FIB4 or you can do a fibroscan and look at the liver stiffness. So here are data that this is manuscript currently under review, where we look at the patients that we classified as class A, B, or C. So class A is FIB4 less than 1.3 or a liver stiffness less than 8. And class C is a FIB4 over 2.6 and LSM greater than 12.5. And anything in between falls into class B. And you can see now, if you look at the incidence, this is a prospective study. If you look at the incidence of deaths, it's 0.07 in class 7 per 100 patient years, 0.42 in B, it goes up about 4-fold. And then when you go to C, it goes up almost by another log-fold. So there is a clear exponential increase as you go from A to B to C. And you see the same thing with liver events, and you see the same thing with MACE, and even with hepatocellular carcinoma. On the right-hand side, you can see the relationship of FIB4 with the predicted probability of death with the confidence limits around this. And so this is a very simple tool. All of you should be able to apply it. And so when you see a patient who has the clinical risk factors, check a FIB4. If the FIB4 is more than 1.3, pay attention, because that is the population that is obviously at risk. And certainly those whose FIB4 is more than 2.6 represents the population at greatest risk. Now, once you've done that, you have to now think about competing risks, because there is no point fixing the liver if the person is going to die of a heart attack. So fatty liver disease is often associated with a number of comorbidities such as hypertension, cerebrovascular, cardiovascular, peripheral vascular disease, heart failure with preserved ejection fraction, type 2 diabetes, chronic kidney disease. Now, the common link between all of these commonly concomitantly present conditions is metabolic stress that leads to systemic inflammation and fibrosis, and which at its root cause is linked to diet-induced obesity, and in the Asian populations, particularly visceral adiposity. So if you think about the treatments, there is already a lot of treatments that are established for many of these comorbid conditions. The one thing I would like to state is that if statins are indicated for cardiovascular risk, you have to use the statins. The risk of statin-induced hepatotoxicity is very low, and the benefits of statin are way more than the risks of statins. Number two, weight loss is a common denominator that improves all of these different types of treatment, and you have to really spend time trying to teach the patient and the entire family how to eat and live a more healthy life. There is also pharmacological drugs being developed. Semaglutide really is leading this pack and is now available also in oral form, although it is not as effective as in the injectable form, but you can see almost bariatric level weight loss with these drugs. And beyond GLP-1 agonists, we are seeing data with GLP-GIP, GLP-glucagon, triple agonists, etc., that actually can produce similar degrees of weight loss. So these are actually leading sort of drugs in the obesity space right now, but the best is, of course, to try to do this the old-fashioned way, which is actually making a change. But you have to pay attention to the mental health, all of the issues. You have to take time to figure out why a patient cannot engage in healthier living. You have to make the whole family change their way of living. If only one person has to eat, a very sparse diet, where the rest of the family continues to eat their very rich diet, that is perceived as a punishment and will not succeed. So the whole family has to eat healthy. Now, from a biology perspective, it has become very clear that lipid and glycemic stress injure the liver and produce organellar injury and drive inflammasome activation, which then in turn drives a chronic fibrogenic response. And this has provided us many targets. From a practical perspective, vitamin E, which is an antioxidant, is very cheap, widely available, and diabetologists have created a major issue about whether it increases long-term cardiovascular problems. But the truth is that it is all about competitive risk. For people who have significant NASH and fibrosis, the liver disease becomes a primary cause of death. So here are data with vitamin E in patients with stage 3 or 4 fibrosis, and you can clearly see that vitamin E actually reduces mortality and improves transplant-free survival, as shown on the left, and reduces hepatic decompensation by almost 50% in patients with stage 3 or 4 NASH treated with vitamin E 800 units per day. So personally, I think this is still an important leading therapeutic. Now, the goal, of course, in NASH is to not only reduce weight, improve atherogenic risk profile, improve cardiovascular outcomes, stabilize GFR, because these are all your competing risks, improve glycemic control, and reduce NASH progression to cirrhosis, because it is when you get to cirrhosis, that's when you have clinical outcomes. So what you can see over here is that thiazolidinediones are limited by weight gain, which is why even though they do produce NASH improvement and even some regression. Now, there's several second generation PPARs that are now coming into play. Inventiva is a pan-PPAR, lanifibranor, which is in stage 3 right now. Saroglitazar, which is available in Asia, is weight neutral, very beautifully improves cardiovascular profile, is neutral on glycemic control. And I think we need more data around NASH progression, but it is already some early data suggests that it significantly improves NASH and is being widely used in India. FXR are bile acid agonists, and along with FGF19, they can cause some weight loss or are neutral. They do increase LDL cholesterol, but they do reduce NASH progression. So I think if you use these class of drugs, eventually when they're approved, you will need to pay attention to the cholesterol and the potential rare risk of hepatotoxicity. FGF21 is a different kind of FGF, which has a wonderful weight loss and atherogenic risk profile improvement, but we still need more data around its histologic benefits. The early data with efruxifermin are actually still based on very small numbers. Thyroxine beta receptors do not cause weight changes. They improve atherogenic risk profile. We don't have a lot of outcomes data yet, and that I think could be an important class of drugs. GLP-1s are leading the pack because they improve everything, and we're just waiting to see. They improve NASH. What we're waiting to see is whether they really can reduce progression to cirrhosis. And then fatty acid, bile acid conjugates also are relatively non-toxic. They're neutral to weight, improve lipid profile, and we're waiting to see whether in phase 3 trials currently that are going on, whether it will improve long-term progression to cirrhosis. So where we think we are right now is that when you see an initial patient, you have to assess all the end organs that are relevant for their outcomes and start with weight loss regimen. I would use only drugs as second line. Use statins and if indicated, and use fibrates if triglycerides are also increased. I would start with a GLP-1, SGLT2, particularly for the diabetic patients, and minimize the use of insulin. When these drugs are approved for NASH, they could become frontline therapeutics. Now, after a period of treating this systemic disease, particularly since SGLT2s and GLP-1s improve the systemic condition, you reassess the patient. And for those with advanced fibrosis who are at risk of outcomes and with active disease, you may need second-line NASH-targeted therapeutics with the ultimate goal to reduce mortality, healthcare cost, improve function, and quality of life. I thank you for your attention.